but I just want to be clear that I appreciate the hard work you put in. You do have some points of view that we're going to share, but this has been very interesting, incredibly educational, important conversation. And so that's what I'll say for the moment, and I'll hand it over to the commissioner.
Excellent. I've been hanging with the drafting committee, and I really appreciate their extra work in doing some work to try to write a report and to get us to a place where we can start to finalize some things. So grateful for that. And I also want to say that I'm dealing with another task force report that was written several years ago with 93 recommendations in it. So I'm liking that this drafting committee is trying to get succinct. So I appreciate that. And so particularly grateful that Sue has done some work on this drafting committee, helping us to try to take that whole behavioral health it and bring it down to some a manageable list of recommendations, because we have all said to each other that with a priority admissions task force or admission to DCT, the big issue behind that is the behavioral health crisis, but we can't boil the ocean and solve the whole thing in this task force. So I do like how we're getting more succinct about the behavioral health world and what are the really top key things that would affect these decisions about priority admission. So I appreciate that we're getting more succinct there. We've got 2 drafts for you today. We had written a draft, Kylie had written a draft out of the drafting committee's work. We had a group that wrote another draft and brought it forward. And so we'll look at 2 things today. You can kind of compare and contrast, give us your comments about all of them. It's all good. And we'll see how that goes. There's some different elements in the 2 drafts. So, you know, we'd like you to really just study them and then and give us your thoughts. We didn't want to go any further without the whole committee. So we've had a couple of meetings, I think, since the last task force of a drafting committee. And we're getting somewhere, but we really wanted to hear from the whole committee. And then we'll have to figure out how to dive back in and try to find our way to a final document. But I am pleased with the progress, and we're getting somewhere, and we're down to some different words in a couple drafts in general. And then I like how succinct the whole question of behavioral health background issue is becoming in our report. So, Kylie, did you have anything you wanted to add about where we're at drafting?
Yes, I know that this is a giant room and we're a little bit more spread out. So if we can keep our voices up so everyone can hear, that would be good. Or, we can all get a little bit closer like family. You don't need to hug the walls necessarily. So
everybody's in the back too.
Exactly. Right. So as the commissioner said, we've met twice as a small drafting team. So it's been the commissioner, Kevin, Sue, Angie, myself, and Dr. Cologne. And in the meantime, folks have done some work. So DCT has been working on the whole report, just the background information and plugging things in. So I thought that I could share just a quick run through of the report, mostly what the main sections are. So you can all see it's too long already and we're not close to done. So there will be some synthesis that needs to happen. And of course, this is our report together. So would like feedback, and you for sure will get lots of opportunity for feedback as we go through. That is way too small.
And can we just be clear, the documents we have in front of us are just recommendations. That's the real section we wanted to dig into today.
That's right.
I was going to show you the executive summary intro background stuff here.
Yep, absolutely. So I'm trying not to induce motion sickness, but we'll start with an executive summary, introduction to the task force, what our goals are, our mission, what our guiding principles are, try and be practical, etc. What the task force report must include, membership, background for the work itself, So the priority admission statute as it stands. The 2023 amendment. A brief synopsis, although it's not yet brief, of previous reports to acknowledge that there has been a lot of work done, lots of recommendations that are recommended, some partially implemented, some not. Sue did a nice job of pulling out common themes of those reports. So far, we've thought it made sense to include the Competency Restoration Task Force recommendations because that is the most salient set of recommendations related to this particular population. It's pretty long, so we might need to cut that down too, but we'll see. Looking at recent trends and statistics that you all have seen, there's nothing new in here that we all haven't discussed in this meeting. Okay, this section is something that we thought might be really helpful to make sure that everyone at the table has a chance to talk about what the priority admission statute means from their perspective. So we're going to ask, and this will be our homework for this time, for every member to draft a short statement about what your viewpoint is about the priority admission statute, and probably more importantly, how it's impacted your organization, your own lives, depending upon what your role is on the task force. So we'll send that out after to be very clear. So folks are speaking to the same sort of thing. We're asking people to not combine responses, but so that everyone and every group represented here has its own words included in the final. A brief summary of the meetings that we had, the goals of each, our process, and then our findings and recommendations. And this is where you have printed copies of this particular report. And then there will be like other recommendations in an appendix, other data in the appendix, other things that we think would be useful. So that is, this findings and recommendations section is the black copy, draft findings version 1. So you can see work in progress. Then the other set of recommendations was created by Angie and Kevin. Angie?
Clark and Sheriff White.
Oh, I'm sorry. I did not realize that everyone had worked on it. Okay. Would you like to speak to your process for coming to these recommendations?
So one of the things that we did in the drafting committee is, try to do the track changes on here. And as we started talking about it, it would have been too much to track changes. So we just started a different document. But what we tried to do is to incorporate a lot of what was in the draft document that we started with. And we framed up a different section for recommendations. And so it's the ones that you see on here, draft 12/17/23. And this, it's a more formatting than anything. And the intro of it talks about the 48-hour rule, having good intention, but the execution of it is challenging given the systemic constraints. And so really pulling those pieces apart and trying to illustrate that the 48-hour rule itself is not problematic. It's all of these other pieces, because I think that from what I've heard or what I've gathered is getting people to receive treatment is not a bad goal. There's all the pieces that come with it that make it challenging. And so the other thing that we had talked about in some of our earlier task force meetings was having concrete items, but yet have them broken apart into what's immediate, what's short-term, and what's long-term. And so this was an attempt at taking a lot of what was already in this first version of the much larger draft, report, and just taking the recommendations. And then, I reread everybody's submissions to the top 10 list and tried to pull those common things together in terms of how might we talk about this? And now please know that we all admit this is very much in draft format, and there's a lot of discussion that needs to happen. And so there are things that are really warrant a lot of conversation in what's written in here. But again, it's a formatting, trying to get us to think about immediate, short-term and long-term, and then also things that are more concrete in nature. Is that what you're looking for?
That sounds great. And then Sue, I failed to mention that you contributed to the other version.
Right, and then also making sure that we framed it as this is an issue across the country, not just in Minnesota, so that information is in there and what those national recommendations were as well. And the other thing I would just mention is we thought yours looked prettier for sure, but also looking at making a highlight, because it's like there's a highlighted section in terms of DCT, but then we need to make a highlighted section around community so that those two pieces weren't lost in some of the detail. But I think the recommendations are somewhat similar between the two. There's some changes.
Yep.
But
Yeah, and the version that's in front of you is not the version after we had our last drafting committee. There were things that we have pulled out. We're assuming that many of you would recommend or say similar things to, and so certainly get into that. Not super substantive though.
Yeah, if I could, I think the idea was, at least in some of these cases, to at least put a marker in the ground, even if we weren't able to articulate what we wanted to articulate, or we got it wrong. At least the point is there in the discussion. So hopefully it wasn't too confusing to have the two things, but trying to edit one in pretty limited time was also really difficult. So.
Dr. Cologne, anything to add? So I think we left the majority of the discussion today to, kind of break over the recommendations, and Chair Ellison, if that's something that you'd like to start with, or if there's anything additional you wanted to add now.
Well, yeah, I'm glad that you all put the work into both of these. Let me ask you this. I've read both of them. And one of the things I kept trying to do as I read them is to try to harmonize them and say, okay, what is common, what is not? Would anybody like to comment on that? I mean, how far apart are these two things? Their similarity.
Yeah, I think that they are very close. I think there are details in them that, frankly, for the purposes of issuing a report, we want to be detailed, but it doesn't have to be overly detailed either. I mean, I think that there are the areas where it might be a little further apart. I think that they're close enough that I don't know as though there's major sections missing out of. That's just my take on it.
maybe the community section, I think, is not in there as much as the other one. And
Yep.
so, which we talked about
Yep.
pulling out and putting some more emphasis on. So some of it is in there, but just not all of them.
I also have another question. So looking at what do we call these things? Draft two? Yeah, yeah,
Document 1, document 2, so I don't
Okay.
think they can necessarily compute.
right. One thing I did observe is that neither one of them talks about workforce development. I know that some folks might think, well, that's getting far afield. But it just seems to me that if we're talking about inadequate capacity, if we're saying to get the capacity to make the 48-hour rule work, you need more people. And we don't have enough of them. So are we gonna say nothing about workforce development, pay, compensation, training?
So the rate issue is in there because that, we
Okay.
increased the rates that you pay more. But because so much got passed the last 2 years related to workforce, providing supervision for free, loan forgiveness program, paying for BIPOC mental health professionals to become supervisors, it's kind of like that stuff is moving and was just passed. And so that's why we didn't include them.
No,
But the
that makes
rate
sense.
issue is an important one.
No, that makes sense. I would say that, for whatever the executive summary ends up looking like, I think somebody should say something about the fact that we haven't ignored that. It was in mind.
Mhm.
What we're doing now is we had sort of a layout of the two versions. And, we're just open dialogue or comment from anyone who. Doctor.
Dan Hurt. So Sue, you help me, if I'm wrong, but I thought that those programs were for physicians or other providers who are fully trained. So like loan forgiveness, those things are for people who have completed their training.
So that's for any mental health professional, so including LEDC, so it's the whole range.
So I'm thinking about like medical students and physicians who are still in training, like residents, who could be helpful in these facilities with supervision. So if there was funding available for people to have rotations on site or supervise residents in these facilities that needed further workforce, that would be separate from like somebody who's eligible for like a loan repayment.
We have now in Minnesota funding 5 residency slots. So it has to be.
I'm thinking of rotations, not like a full program.
Right, and I don't know how that works or how you fund it. I just know about residency programs.
I think that kind of gets at what we need to do here is there are a variety of ways to expand the workforce. I know for DCT now is working on trying to staff up and expand capacity that way. And that's obviously one clear way to get immediate capacity is staff the facility that we have, which I think has been your point all along, right? And so I think in our recommendation, whether there are means in place that do that, or whether there needs to be additional things, we just need to say we have to staff, have adequate staffing to meet the need, and that needs to be up front and center, like you were saying.
Other reflections?
Well, I just, as part of staffing, I seem to recall there was some conversation, maybe I missed it, about safety for retention purposes. So that we invest in ensuring that our facilities are safe and for the patients as well as those who are employed there.
Sure.
That was education and training, right? As I recall.
Okay.
Right? Or was there other things about safety?
Well, I'm just, when I think of safety, I think of a facility that I stayed at in which there was a nurse's table or kind of like a bar area, and the nurse would be behind there. And this nurse would be surrounded by 4 or 5 patients all asking for something. And that seemed to me like a very high stress situation for the nurse, which would result in a high stress response to the patients. And it was not a healthy situation. And this was not a one-time occurrence. This was a daily occurrence while I was at that location. So I think that there's the potential that there could be more there. Would it be a matter of improved infrastructure? I don't know. I'm not an expert in those areas. So it just seems like whenever I read through these, that was something that came to my mind.
Focus on safety.
Yeah.
People feel that the answer to the charge we have lies within these pages? Do we capture it?
Not yet.
Okay.
I think there's more work to be done. Thank you
Sure.
personally. But
Is there anything missing?
That's what I mean. What I mean is, we may not have refined it, but is it in here somewhere? You understand what I'm asking you?
I felt like this was a good start, but I remember you said shoot for the stars,
Yeah,
but I didn't really feel like there was a lot of huge ideas.
yeah. And let me just say, when I meant shoot for the stars, I mean, one thing that Jodi and I have talked about, and I agree with her entirely on this, We cannot solve the entire problem with the mental health system. We've got to solve the part of it that we've been charged to try to get to. But what I don't want to do is go back to the legislature and they're like, you know, if we did everything you said, we still wouldn't be on the path. So I want to be on the path. Right? I want to walk in that white building across the highway and say, if we do this, we will be in a good place. Do you think it's there? Something missing?
I really think a lot of it is there. I think, you know, when we discussed this earlier this week, there were some changes we wanted to make in terms of, you know, when we talk about beds at DCT, it's beds and staffing. You know, it's not just the physical beds, it's the staffing, so that you can also take people who might have more challenging needs. I think adding in some of the intensive things like the sort of community treatment teams, you know, some housing models where you provide more increased support. We know the locked IRFs is also going to be an important piece of this, trying to get that through Medicaid. But otherwise, I mean, again, some of these things have been in several reports over the last decade. So it's like, yeah, this is what we've been saying that we need to do in order to address these issues.
You know, so I'm looking at the recommendations on the overall behavioral health. And I don't see funding the rate study. Did I miss it?
That's in draft number 2. Draft 2, yeah, so we've got draft 1 and 2, and we've got them, just have, you know, we didn't have time to really totally merge the two, but
It's draft 2, long-term number 1.
No, has it been funded, or it's been funded but not implemented, or the results have not been funded?
the results are coming out and, right. So we don't have to do the rate study, that's my understanding, it's being done or almost completed, and then we have to implement it. And that was the change we talked about this week.
So implementation under long-term number 1, implementation of rate study findings. Again, the wordsmithing piece, it can be fund and implement, you know, so just to clarify those pieces. That's the intention of that. And so you'll see it should be struck under immediate number 7 because it already has been authorized, so you can take that one.
I think that the answer is largely in here. As we work through it, there will be some discussion of, you know, how it's gonna look for sure. I think the balance that in trying to write it is, do we put everything in here so we do shoot for the stars? Or do we focus on 3 to 5 things that we think needs to happen first and are doable? And I think that's a discussion that we need to have.
See, I actually think we can do both. And here's how, in my thought. We come up with like, look, here's what we believe needs to happen short term, medium term, long term. But we recognize, and this can be done in executive summary and other places, that these other things are impacting this. And we're not proposing to solve all this. We just want to make a marker that it is there and it affects this problem. But it's really outside of our purview and somebody else has to solve it. But we believe these 4 things, these 6 things, however many things we come up with, will help us deal with this priority admissions and the 48-hour rule. Let me ask you all this question and put this in the category of candor, okay? In good faith, right? And I'm about to start some mess here, so forgive me, all right? When I read these 2 things, what struck me is this one here seemed to, and I'm talking about the version 1. The sentence goes like, because the priority admission statute placement within DCT programs is not based on clinical need and individual circumstances, but rather based on a statutory obligation. And this one over here starts with, the rule is that the task force concludes that the 48-hour rule itself is not problematic. this one seems to suggest that we have the situation because we have a legalistic approach and we're trying to, it's not based on a clinical need, it's based on meeting the needs of the statute. And this one seems to say the statute is fine. Is that a problem? I mean, if we could just talk like candidly for a moment. Kevin?
I don't think the statute's fine. I think we're here because.
Okay.
It isn't fine, but I think the idea that the problem starts with the 48-hour rule is too narrow.
Okay.
And the 48-hour rule came up to fix a problem, which has not been fixed, right? So the problem is that people are waiting too long in jails, hospitals, and the community. That's the problem, right? And the solution is, how do we get people into the proper treatment facility as quickly as possible, right? And so the 48-hour rule shows what happens when, you know, you address one aspect of it, right? But not the other aspects. So the question is, do you change your focus, you know, so you focus on one thing and make things worse for the other groups? Or do you address the root problem, which is there enough capacity? So if 40-hour rule or whatever the time is, that's not the real problem because we have adequate resources to put people where they need to be when they need to be.
Okay. How do people, any react, Sue?
I might massage the words a little bit, that the intent of the 48-hour law is not problematic. It's the implementation that then caused lots of other problems. But the intent was certainly, yeah, we don't want people with serious mental illnesses languishing in jail. So the intent was okay. It's just, you know,
No
with the
capacity.
increasing numbers and, you know, all of that kind of stuff just led to a mess.
Yeah, I would say, you know, from a defense perspective, the 48-hour rule actually worked for a short time. And so I don't think it was a problem with the statute so much as the capacity issue that they've been talking about. And it's just developed now into a complete crisis in terms of lack of capacity.
Can you describe when it worked?
When it worked,
Yeah.
very early on, right after it was set up, there was monitoring going on in Hennepin County, whether people were getting out of there in 48 hours from the jail. And for a while it worked. Then it started going back, you know, and then it was, you know, a couple of weeks, then it was a month, you know, and so it was
So
a
you think it
gradual,
worked for the correction side initially?
right? And for, you know, my clients who are in jail, who I was advocating should not be in jail, they should be getting treatment.
Yeah.
And so, you know, prior to,
I feel like it worked at the expense of the people who were not in jail. So it worked for one portion of the community, but not the other portion. And when I read this part, that piece, I read this as an effort to be politically correct and not offend the people who were invested in the 48-hour rule. And say that you tried to solve the problem the best you could at that moment. Your intent was pure, but it was always problematic.
right, but I would argue that the statute wasn't problematic. If there was adequate resources, it would have been fine.
But you probably wouldn't have needed the 48-hour rule if they would have been adequate resources.
Well, that's,
Doc, I think your hand was up and then right down here, yeah.
Yeah, I mean, when I read this in our last meeting, I didn't make a big deal of it because I thought there's a lot of wordsmithing that needs to go into it. It's hard for me to say that the statute was right, because I don't know where the hell 48 hours comes from. What is magical about this number 48 that was created? And early on, it may have worked for a little bit, but I heard stories of basically people being put in the sheriff's car and driven to Anoka and say, we're here. We're not leaving until you make a bed. And there's only so much capacity to do that, where you can create a bed. So I think the intent of the 48-hour rule is what I think is what we're alluding to. There's people languishing in jail who need mental health care. There's people languishing in community hospitals who need mental health beds. So the answer is that there's a need on both sides. So I don't want to argue with whoever drafted the 48-hour rule to say, man, you're really out to lunch. And I don't want to create that kind of a political fight. But the argument is the intent to get people mental health care is what should drive the changes. And however you want to say that, I think that was the intent, and I can live with that. And politically, if this group needs to use words to appease somebody who put a lot of effort into it. I can live with that as long as we address other problems. My second comment is that when I saw the first draft, I pushed a lot for putting stuff up front. Because frankly, I raised this at the early meeting. I have no clue of what all these other task forces have brought forth and or what impact it will have. You know, I knew, for example, that the restoration of competency task force was going to come to life, and I kept saying, I got to hear about that to see how it's going to affect the rest of it. And Sue or whoever it was that worked on the first document has really extensive documentation of all the previous task force responses and recommendations, which really shoot for the stars. So if you read all of that, it's all there. The question about upfront access, programs in the community, it's all in there. But you have to go and read the rest of it. And I thought it was distracting because frankly, by the time you get to the third page and then reading this task force came up with 25 recommendations. This one came up with 10. And after a while, I was just swimming, kind of knowing where you go. So I think a trade-off, which I don't know how you do it really, is to be able to focus on what's practical with regards to the 48-hour rule, but with the background of understanding there's all these other things that are either being worked on. And I heard a bit about what's being worked on and what still needs to be worked on. Because there are a lot of system issues that need to be addressed. And this is just a tiny little part of it about how do you get somebody who's committed in the jail or at an emergency room to a hospital. This is a small part of a huge problem. And I think that's what's missing in the condensed front part. But really, if you read the whole report, it's all in the background in that. And does it go in an appendix? Do you draw from it? I'm not quite sure what to do with it. It's kind of a
Thank you, Doctor.
My comment is along some similar lines, that I think it's about the implementation, but I also think that systemically, that's where it didn't work the best, is the systemic side. But for some people, it worked really, really well. So I kind of look at this as a pendulum swing. Like, we were getting a lot of people from community sites into state facilities. 48-hour rule comes, this pendulum swings the other way. And then now everybody is coming from the jail setting. And so when it was over here, the majority of people were coming in from the community side. Then it's over here now, basically only people from the jail are good. So on either side, it's working at first, prior to it, people were getting in from the community. Then people are getting in from the jail. So it's working for individual people because they're getting in, but systemically, it's just, I keep hearing the balance needs to come.
So,
But I think an important part is that the number of people deemed incompetent to stand trial has increased rapidly.
Yeah.
And so it isn't just, balancing between the two. It's all of a sudden this group grew exponentially
You're right.
across the country. And so that also led to all of a sudden this not working anymore.
And so wouldn't you say the whole issue has expanded dramatically? Behavioral health issues in the community have grown in the last 5 years.
Oh, and we know the prevalence rate has
Yeah.
increased. Yeah,
We
that
keep saying capacity, but the problem is bigger,
is both.
which is why the capacity is not enough. I just want to put that out there. So if we're going to draw giant conclusions, one of them is behavioral health crisis has grown dramatically in recent years, and there wasn't enough capacity before. There really isn't enough now.
I agree with what everyone is saying. I would just add that when we say capacity, we have to be thinking well beyond DCT beds or spaces, because we could build 1,000-bed hospital and that too would be filled and we would be having the same issue. And we've seen that in other states. Washington, for example, they didn't build 1,000 beds, but they did build additional beds and they were quickly overrun. We need to be, I worry a bit about how much we're focusing on DCT capacity and not enough about building the other capacity that needs to happen, novel levels of care, treatment in jails, et cetera.
yeah,
I think it's a great point because, anytime when there's a scarcity of resources, and that's the problem, I think we all agree on that. Then you're looking for any way you can to expand capacity in the biggest sense of the word. So if there are alternate treatments if you move people in and out and, get the problem in the bud, there's all that kind of approach that needs to be thought about. That's why it was important for us, I think, to think in terms of immediate, short-term and long-term. Because if you're thinking, okay, we want to, in the next 6 months, you know, a year, whatever, after the statute, we want to be able to move people, you know, from hospitals, you know, into proper placement. And we want to keep moving people from jail. And we want to make sure that there's some people from the community who are, you know, have really acute issues that they're getting the proper treatment. If you're going to do that, what's the quickest way to have an immediate capacity expansion? And that might be more on the DCT side, but that's not, as Dr. Stevens said, that's not a solution. I mean, the solution is more like, you know, the stuff that Sue's talking about, both on the short term, you know, but also in the long term. You've got to build an entire, you know, community-based system in order to handle all this stuff. And so I think that's why I think the structure of the report is going to be really important. What are we going to do that's going to give immediate? We're not going to fix it all. Well, how can we get some immediate relief? You know, then what's the next step? And then what's the longer term approach that hopefully will be sustainable as this crisis continues? Hopefully, well, maybe not a crisis, but as this problem continues to grow. It's not going to get smaller, I don't think, in society.
I'm just thinking back to my career as a software engineer when dealing with complex systems. This complex systems have complex problems, and to try and solve those all at once is that's quite an undertaking and oftentimes not successful. How I approached that was to iterate. Here's some changes. Let's evaluate what the outcomes of these changes are. Because, for example, the 48-hour rule, it seems like was implemented with very good intentions, but it had follow-on effects. So are we able to acknowledge that we're going to make some changes that might have some follow-on effects, and we might want to reevaluate where we're at a point in the future?
Let me say this about the 48-hour rule. And this is, all you guys know more about this stuff than I do, I guarantee, way more. But I'll say this. The point is, get people who've been determined to need a hospital facility into it as fast as possible. So 48 hours, or it becomes sort of a symbol of as soon as possible. Okay, let's say, but if we don't have a number, then we just kind of, that becomes too flexy and we end up not doing anything. So it's kind of like saying we're going to be completely net zero carbon emissions in however many years. If you don't have a year, you have nothing to shoot for.
It seems like a 4 days so far.
I was just looking at some of the bullets. This is the version 1. Expand DCT capacity, expand non-DCT capacity, expand access to IRFs, fund jails, expand community capacity, etc. I think we are shooting for the stars if we actually did all that. And I love putting all the former reports in the appendix so people can say, how many more times do we have to say this before we actually do it? And so I think we are shooting for the stars to finally fund our behavioral health capacity. And I'm sorry, but I'm being practical. We now know the forecast for the next year and how this session is going to play out. And our ability to completely fund the capacity of our behavioral health services across the state in this session is going to be very, very difficult. And so we also need to have a priority admissions plan that works now, even when we don't have all that capacity. So we're going to have to make some compromise to free up some of the capacity that we do have with an appropriate priority admissions plan while we wait for the day when we can actually fund the behavioral health capacity across the state.
But do you believe that there can be some enlargement of capacity in the future?
Maybe.
The problem is that all you're going to do is swing the pendulum back. So now everybody sits in jail and people move to the hospital.
Nobody's saying that. No one has ever said that.
I know, but I was
But you
saying.
keep saying that.
Well, no, but look, I mean, the easy thing to do is to say, they're okay, they're in an institution, right? They're not hurting anybody because they're locked up, even if they're melting down. We've got other public health needs we need to solve, but we're not focused on the individual need. So what I've been saying is that I think there's room for prioritization as long as it doesn't cram everybody else down the list.
So,
Well, and I think, because I've heard Speaker Hortman in a smaller meeting saying, yeah, I don't look for much money at all. But in terms of one-time money, there are some things like investing in new ACT teams. That's not necessarily ongoing funding. It's Medicaid under forecasting. So we could do that. My pet project, volunteer engagement, right? You know, in terms of a pilot, trying that for 2 years, it's not, you know, built in to the base funding. So I think there are some things in here that have a possibility of getting passed, even if, you know, they're saying they're not going to do a lot that's going to have to go into the future. There are things on here that we could do, fixing the locked earths issue, you know, things like that.
So probably my legislative naivete, part of my thought when we're going through this is that there should be a template that allows people who have ideas of what is practical and can be done today to attach it to this and say, based on this, this is what you should fund, because frankly, it's overwhelming. You know, I think that the problem is so damn big that it's just overwhelming. And I think of my hospital as a microcosm of what you're talking about. I have people sitting in the emergency room, waiting for a psych bed, sometimes in restraints. I have people on the medicine floor that I see who need to go to psych, and I'm getting clobbered on the medical floors because this guy doesn't belong here. Well, I have somebody who's been in the emergency room under Dr. Hart waiting for a week, and I don't have a deadline except that I know neither is good. So you're constantly trying to figure out what do you do, I would say the least bad option, right? And it's tragic that we need to do that, but that's where we live. So my thought when I first met with the group to review the first draft is I don't think Keith Ellison is getting sued because there isn't an early intervention program. You're getting sued because people are stuck in the jail and are not moving. So if this task force didn't address some way of at least beginning to address that acute problem, then we missed the goal. But I agree with you that until we fix all the other problems, this is going to continue to grow and get worse. How do you balance those two? And I thought that inserting some of those previous findings and recommendations there and making sure that somebody is anticipating that you need to fund ACT teams, fund other options. For example, you know, people sit in an emergency room, can't break their mind where there's no psychiatric care, or people sit in a jail where there's no psychiatric care. Because the mental health system has been siloed. Mental health belongs in a bubble somewhere else. So why can't we provide more care for those who are waiting in the jail so that they're not suffering or just waiting? Why can't we provide more care for the people who are sitting in the emergency room waiting for a psych bed so they're not just sitting there in restraints or running away? I mean, somehow there's got to be a stepping over these lines so that we provide care across all of these areas. Well, how do you do it? Strategically, I don't know what you do in terms of the legislature, but I think this report should highlight some of those needs so that somebody can come up with more practical ideas. And if we have some, of course, to suggest them. But I thought we needed to kind of focus on what do you do with the weights? What do you do with the priorities? Who goes where? Because this is what I'm consumed by every day. You know, who goes upstairs? And believe me, the poor triage nurses, from my standpoint, you never get it right because I'm not happy, right? And I don't want their job. So who makes the decision and how do you make it? If there's more beds and it's easy, I love it. Somebody says we have an open bed, man, it'll be full tomorrow. But at least for a day, you don't have to try and pick. So yeah, there have to be some criteria for who gets moved in the system. You know, you were asking me what the criteria would be. Hell, I know. How do you gauge all of that? And we've done the numbers, right? If you figure somebody who's been waiting for a bed, how many other people could have gone in and out? How many more people could you have mobilized if you get one person to the right level of care? So if you have somebody who needs to go to security hospital and also I've had to close down an ICU so that that person can be managed, that means I've taken 10 beds out of commission and that probably needs 50 patients in a couple of weeks. So how do you get people where they belong? I think that's the hardest part in terms of mobilizing the backup. And if anybody knows how to do it, please. This is kind of what we need to focus on, I think.
You know, Doug, in connection with what you just said, and again, forgive my ignorance, both of these versions, when you talk about how to prioritize admissions, lay out some criteria which could be employed to do that. How would that be? How do we imagine that would be administered in a way that? How do we imagine that would be administered?
I can tell you how we currently administer it
Yeah,
for those that are appropriate for, like our CBHHs, for example, primarily not people that fall under that are under the priority admission statute. And it's essentially how we've laid it out in version 1 or draft 1. First of all, we need to pay attention to if there's a federal prioritization requirement. So for substance use disorder, people that use IV drugs need to be prioritized first, and that's a federal requirement. So that's first and foremost. Second is people that have been on our wait list the longest, who have been waiting the longest. Medical acuity. So this is a little bit tougher and depends upon the individual. So significant symptoms of illness, which place that person and others at risk. Whether the referring facility where they currently are or any other setting can provide adequate treatment. So this gets down to DCT's, real mission, which is to treat those that others can't or won't. So to be the end of the line. So let's exhaust all of our possibilities. So this means that the jails often don't have adequate treatment. This means that community hospitals that don't have a psychiatric unit don't have the capacity. This means someone sleeping on someone's couch and threatening the neighbors, but no one will take into an emergency room would be maybe the right answer in that particular case. And then one that we don't currently use but have considered in the past is what's the impact on the referring facility? So the situation that you just explained is what is the impact of taking care of this person on the outside facility or the referring facility? Or is a jail just so overwhelmed that they're losing staff? Those are the things that we take into consideration. So it has to be fluid. It's like, I say this all the time, it's a chessboard with 10,000 pieces and they're all moving of their own accord. Which is why we need to rely on central pre-admissions to really manage as much of that as they possibly can. And then we make the best decision we can in the moment. We understand that it is not as transparent. It's not transparent mostly at all for various reasons, and that needs to change. And happy to let other people into that process and share some of that responsibility. But it needs to be nimble, and we need to be able to operate how we manage admissions, but are happy to have criteria, guidelines, but we need to be able to work within that as well. Is that helpful?
yeah, very helpful.
And that was how this is outlined.
Yeah, and it still means we either have to do inputs or greater capacity in order to meet a increasing demand.
Anyone have questions about what I just said? That was a lot.
I don't know if it's a question. I think the bullet that tends to cause, on an operational sense, the most kind of heartburn, if you will, is the one about whether the referring facility the person is currently in or any other setting can provide sufficient treatment, because that becomes very subjective. And what happens, what I hear from our local hospital is, they can't put a person on there because they do have, on the list, because they do have a psychiatric unit, but it's not safe for that individual in their unit, but their person is deprioritized or not on the list. So I hear that from our hospital. I also hear from our jail that, prior to the 48-hour rule piece and some of the other pieces that, yeah, the jail doesn't provide the service, so they don't do it, but they could. So therefore they're not. So some of it's in that implementation of it, and it is in, so those are that's the bullet, I think, from the county perspective, that when we're hearing from either our jail or our hospital or, the case manager that's working with the individual who's still at home and we need to get them into a hospital or into a DCT bed, that's probably the one that causes most concern without further definition.
I can see that. Practically speaking, this is everyone's responsibility, and without, what's the incentive for people to create treatment opportunities if the state is responsible for everyone? So we have had hospitals that say, yeah, we have a mental health unit. We won't take committed patients. We won't take this patient. It's a decision, an operational decision on their part, and one that they need to make, but we cannot, we obviously can't take on most of those people.
And I think in that exact situation is where that next bullet comes in, other negative impacts to the referring facility, because they may have to clear their entire unit, which has happened, right? And so that's where I think the intention of this is well, natured. I worry about some of the application of it.
What if, Angie, if it said instead of can provide, but is able to currently provide sufficient treatment? So it's like, yes, we have like the Worthington jail, they have someone who can do an injectable, that kind of thing. So it's not, yeah, you could if you hired someone, but is that something that you have available right now? Whether that would help?
Yeah, I don't know. I'd have to think about that a little bit. I think it's worth exploration for sure. I just think about, is it the start of it, or is it the end of it? So is it, to me, it's about the outcome, the negative impacts to the individual or to the environment or to those in that setting. So, yeah, I don't know. I don't have a great answer.
Just knowing we don't have that magic wand, it's like, so, but I hear what you're saying. It's like, well, sure, we could hire someone, but we don't have anyone available. But if they do have someone available and they could do that, then that person might not be as bad a situation as someone at HCMC where you just had to clear off a bunch of rooms because somebody has such aggressive behavior.
Mm-hmm. Well, yeah, I think that exact situation happens everywhere. Yeah.
And quite frankly, we experience this in our own facilities. So if we have someone at a CBHH, for example, that is threatening or maybe has been restrained or secluded in the past, they would immediately be transferred to AMRTC. Now we really try to avoid doing that for obvious reasons. So we've set up things in place where we offer internal consultation. We found that perhaps people aren't adequately medicated, or maybe not adequately, but optimally medicated. They've not tried behavioral management techniques. It becomes easier to, okay, you take them. So we had to build that internal capacity. So I know exactly what you mean about that too.
Good. So let me ask you this. So it's about 3:05. One of the things we want to be doing right now is thinking about recommendations. We've been sort of discussing, the problem and solution, but would anybody care to comment on the importance of a particular recommendation in either one of the versions? Anything, so they both contain recommendations about what the admissions criteria should be. And they both have some ways to do that. Can we focus some attention on proposals at this point, recommendations? But here's a question about the criteria, just sort of the admissions criteria. If we do that, if we use these criteria, do we now sort of avoid the problem of the jail people are getting in, but the hospital people are not, or the hospital going to have the hospital people get in and jail people won't get in? Are we at least solving the problem that at least there'll be some level of, I'll use the word equity from the various institutions? Do we solve for that problem with this criteria, or we don't?
I personally don't think so.
Okay.
I think the criteria that's laid out in number 1, as Dr. Stevens said, is really kind of how you're sorting for the CDHHs right now, right? And I don't know as though it's drastically or really any different from what it was in 2013. So unless we define things a little bit differently, it feels like we would just be going back to what it was in 2013. And if we're defining that someone's safe in jail, not receiving treatment, over someone in a hospital I would be concerned about the lack of definition. And so in the second one, it's not super detailed, but there are pieces that we added in here, like intensity of treatment needed. I think intensity of treatment is to me different than acuity in terms of acuity of symptoms. Intensity of treatment is this the short-term type of treatment that we're looking at? Is it about just getting the person their neuroleptic medication because they have been on it in the past and it's successful? Or is this a first episode psychosis thing that may be more complicated that needs longer term treatment, and we might be talking about months of treatment? Some of that we don't know, but some of it we can predict. I mean, we can be prospective about those things. I think the provisional discharge status is also an issue from a community standpoint, is that we're talking about people that have been through the process and now they're provisionally discharged. And it feels like those individuals are kind of like going back to square one to get that treatment that they need and deserve.
I like both of those.
Okay,
I like intensity of treatment rather than acuity.
yeah.
And it's really about what's required.
I appreciate that, because when I look at it, like, you can look at two people and they may look the same clinically, but their treatment can look very different because it's so individualized. So I would say those things need to be in there, and then really understanding that it's not that treatment can't happen in jails, and I would defer to the sheriff to speak more to this, but yes, it's not the best place, but it's also not always safe. It's not the safest environment for that. So.
I mean, I think I like those additions, and I think it's important, also, in the recommendations talking about, what kind of care can be provided in the jails. Because I mean, I will be honest, we still get calls from people who are trying to get their medications in the jail and can't. And even ones that I understand could be abused in the jail, but if you're manic and you've been manic for a long time, you might need to take something to sleep, honestly, to kind of stop that. Man, I'm not a doctor, but that's what I hear, right? And so,
You're not wrong.
so, I think that has to be a part of this too, is how can we make sure that some folks can get some of the treatment that they need in jails, who might just, with a little medication, not have to actually end up in state operated in DCT. So I think that has to be part of the recommendations too. And we do get complaints, which we refer to the new ombud. I hate that it's just ombud. It just sounds so weird, but it is an issue that we hear about.
And
I don't remember, Sue, whether that provision, that recommendation is contained in either one of the versions, and maybe it is.
I thought we
it's in
had.
there.
I thought we had.
Okay,
it
good,
here.
good.
I think so, and if I could just piggyback
Yes.
off of that, Sue, and back to one of the other conversations about the criteria, I think it's a little tangled up for me if we haven't answered the question about what kind of or level of care would be provided feasibly in the jails, to then have that be a condition that we're looking at in terms of the criteria. It just feels like it's a bit of an unanswered question. And so I think if we could come up with some sort of a framework about what would be possible in various settings, as opposed to just DCT or just jails or just any one particular location, and looking at it somewhat multifaceted, understanding the parameters of the work that we have to do here and the timeline that we have. But I think if we've got any number of sort of variables or have an impact on other parts of the recommendations, it feels a little bit cart before the horse for me.
So I hear what you're both saying, but I think it's also minimizing the fact that correctional facilities are the largest mental health providers in the country. So there is no way to have that population suddenly be in a traditional treatment setting. There has to be some type of structure built in to the jails and prisons that acknowledges the need. And there is no way for everybody who needs care to go into a traditional community setting. So I think we have to build both. there is, and we also don't have to come up with criteria about what needs to happen in jails and prisons. The National Commission on Correctional Health Care already has those like standards. They just have to be implemented. They have to adopt those standards and implement them. So we're not really reinventing the rule. We're just acknowledging that both need to happen.
Good. Okay, good. Well, we're moving along. Well, I hope somebody's capturing all this wisdom.
You're recording, right?
Being recorded, yep.
Good, good. Any other reflections on recommendations contained in here? Maybe elaboration? Maybe somebody doesn't agree with a particular recommendation, that's fine too. But let's just focus our attention until 3:30 on the recommendations, what we think about them. Feel free to pluck one up as you choose. Yep.
I hope this is an easy one. Number 5 under immediate on the second one, which is to expedite the submission of the 1115 waiver, as we've been talking about the jail side of things and access to healthcare. I would hope that would be an easy one to discuss. I think the details of what would be included in that application or in that request, would warrant lots of discussion outside of this room. But I think that could really help, as you talk about someone needing their medications when they're in jail, this could significantly help that. So, and then also as they come into jail and as they release from jail.
Does everyone know what the 1115? I'm not going to say that because that puts someone on the spot. I bet not everyone does.
But there's the caveat there that I just want to kind of bring up is that most of the applications for the 1115 waiver is a 90-day, so that you can get Medicaid 90 days before you're released, which is very difficult in jail because we don't know exactly when someone will be released. We had heard that 1 or 2 states did something for pretrial, and that's what we need to look at. But right now, my understanding and talking to staff at DHS is they were looking at the 90-day, so which will be very helpful for prisons, but honestly not very helpful for jails. And so I think we need to find out who those other states are to see if our application should look about pretrial Medicaid expansion instead.
So basically, what number 5 says is get people signed up for Medicaid fast.
No, Medicaid is actually, if you're on Medicaid when you enter the jail, it's suspended for a year. But you can't use it in the jail. But the 1115 waiver would allow you to use it for someone who's incarcerated 90 days before they're released.
Okay.
But figuring out the 90 days for someone in jail about when they're going to be released is like really, I think pretty complicated. And so if there have been some other states who did pretrial instead of 90 days, then I would say if we're really focusing on Medicaid for people in jail, then that's the approach. But we need to find out which states those are, what they said, did they get approved by CMS, things like that.
Why is it shut off at all?
Because Congress never wanted to pay for the health care of people in jails or prisons, basically. And to change it now would be a huge fiscal cost.
Because they don't get sick.
It's the same reason they have the IMD exclusion, right? They didn't want to pay for treatment for people with mental illnesses. So they excluded that from Medicaid. At the time, those were the only facilities that treated people. So just pure discrimination.
So could that be a recommendation to expand for all pretrial individuals?
Well, we need to look first to see like who really did that before we put it in there. So I think the broader statement about trying to figure out how we can use Medicaid in jails would be good, and under the 1115 waiver, and then figure it out.
I also particularly like that one because it's not a cost. Like we don't have to ask. My understanding is everything's been authorized. It's just having that happen.
States need to apply to the federal government for it.
Which doesn't make it simple.
No, but it is a step. It is something that is we're not necessarily waiting for others to have authorization.
We're not waiting at the state level.
No,
Yeah.
you have staff working on it now.
Yeah.
So,
Yes.
yeah.
One thing we could also do is approach our Minnesota delegation and ask them to try to fix something in Washington.
Yeah.
You don't think so?
Well, not on that broader issue, but we are, I was in DC, I don't know, 2-3 weeks ago, and we're trying to get them to help on the locked IRTs in Medicaid. So that's something.
On what?
The locked IRTs facilities in Medicaid. So they're all willing to help on that. And Senator Smith's office is working with CMS. Everyone said, I mean, all of them, Republicans and Democrats as well, said they'd sign on to a letter to CMS to try to do that one. But the broader Medicaid and criminal justice issue, that's, I mean, they would all vote for it if it came up, but it's, again, the cost is enormous. And so I think that happening anytime soon
Sure.
is not going to happen.
But that would be included in version 2, or draft 2, whichever, 1D. And the top dot points on page 3 of the other recommendations. Expand community capacity through development of types of novel services, levels of care, including like non-temporary.
Yeah, I thought we had locked IRTs and the other one.
It is, they're both there, yeah.
I have a question about, I'm sorry.
No, you got it. You're up.
I have a question. I was looking at the 1115 provision, number 5, and I was looking at number 4, talking about Jarvis orders. And I'm wondering if that recommendation is to obtain and utilize Jarvis orders, because I think obtaining Jarvis orders could be a huge benefit for this whole problem, because I have many clients who are in jail that are refusing medications. And if they were medicated, it's very possible that they would become more stable and, more placeable.
What's the status quo?
Well, for a long time, there was no effort by jails to obtain Jarvis orders that I know of. And I'm talking about Hennepin primarily.
Mm-hmm.
Now Hennepin is through HCMC applying for Jarvis orders for individuals who are in jail. And so once that order is obtained, then medication can be administered. And typically that's going to reduce the acuity of that individual once they start getting some medications. So I don't know if 4, contemplates that as part of what that recommendation is, but I think that's an excellent immediate kind of response to the situation, because the problem, again, as defense attorneys that we're grappling with is people are often not getting treatment in jail. And, and just so very fundamentally, that makes the commitment unconstitutional. There's got to be treatment. That's, I think, part of what happened with that 48-hour rule. It's like, you got to have treatment if that is going to be a valid constitutional commitment.
Now, if this were to happen and people did get stabilized in jail, whether they want to be or not, would that relieve pressure on the, and like to what degree?
Take them off the
Well,
list.
so they wouldn't have to go to ANOCA, as I understand it. They could possibly be discharged into into an IRTS in the community, or, some other kind of setting, because they're already under commitment, obviously.
Right, so
and
how
you
much
could use a
pressure would it
provisional
relieve?
discharge. I don't know what the numbers are.
So-
If they're treated Jarvis and then they just sit in jail, then it doesn't relieve a lot of pressure. If you could skip the step to, a crisis treatment program and put them into a proper community, treatment program so they're out of jail as they complete the treatment or as they go through the process, then I think it would.
Okay, so
Doug, remember when we redid the Commitment Act, there was not agreement to allow the jails to actually do that. And so then we just said that they could implement it. The one caveat that might change all this is that since we're trying to separate out competency restoration and commitment, that might hinder that a little bit depending on the severity of the individual, because again, we're trying to separate those two things out since so many people didn't meet the commitment standard under the new competency restoration law. But I would love to be able to have the jails petition to do that. But we just couldn't do it before because I forget who at the table disagreed. I don't know if you remember. Or
No,
Doug,
I
you
remember the
but-
conversation, not specifically
Yeah, so I remember we wanted to do that, but there was some group that opposed it at the time, but that was 2020, so. I'm
Did
all for
people
it.
fear that there would be some kind of an abuse or something like that? Like,
I thought it was
they
actually
medicating
from the
too many-
defense attorney, so I'm glad to hear you say
That
that.
oppose that?
Yeah, that's what I remember from back then. I mean, I don't think it was you, but I think there was, there were other attorneys at the table.
Okay.
But we did get it so jails could do existing Jarvis. So,
I think there was anxiety from a lot of sources.
No,
Dr.
I had a couple of concrete questions. Namely, I didn't know who would be deployed for the rapid response teams to the jail to do the Jarvis. Like, are there enough actual teams who could do that? So that's another workforce question.
Right.
or we had talked about, like using, it doesn't have to be state, it could be CCBHCs, community mental health centers that, we could use to deploy.
But there still would have to be enough people that you could deploy. So wherever they came from, we'd have to have enough of them.
Yeah, I think that's worth pursuing. And there's different models. So we're familiar, I think, mostly with the California model, which is new, which state has oversight. But the actual administration and so on is done by jail staff and their partners, but the state is responsible. I hear from California that it is very intensive, time resource wise, but it seems to be a good approach so far. But the state doesn't have, there's no way, I'm not gonna say that. It would be a big addition to state resources to have ACT teams to go do Jarvis, because it's not a one-time thing, right? You have to meet with the individual, you have to, do all of the things. So it's setting up a treatment relationship. And we know that that's best done by people that they're around and evaluated every day. But recognizing, and I'd love to hear from the sheriff on this, that there's just not the capacity or the skill set, if I may, in most of the jails right now.
Yeah, all of that. And so many facilities are different in what they have available, from Hennepin to Cass County to Kitson County. What does that look like in each of the facilities? And you said it's a state responsibility, but then the counties would administer it. Are you saying the jail staff or medical staff?
I think there's variability because California is a big state, so
Right.
I don't know enough about the detail. I know just enough to be dangerous at this point. So,
Because I would be concerned about jail staff administering medical neuroleptic medication, and then there's nobody following or seeing if it's working or not.
Right,
I
no.
mean, because we're 40 miles away from a doctor or a hospital. And
Which is telehealth might be helpful.
I was gonna say,
right.
But my other concrete question is, maybe it's just a few orders that I've seen. And so let's say somebody did get stable in the jail. Some of the orders say you still have to go to ANOCA. They don't say get stable and then you could discharge. So it also would have to seem like the commitment orders would have to be changed. Because they say, they say Hennepin County or suitable facility. So I'm just wondering, would it be realistic for somebody to be involuntary medicated under the way most of the orders are and then just discharged?
Yeah, individuals are committed to the Commissioner of Human Services, who delegates that responsibility. So within that, we have flexibility. And if someone doesn't meet hospital criteria, we'll work with the county to say, or the referring facility to say, this person it looks like they could be provisionally discharged. Can we come up with a plan? And we try to help you.
Okay, and
So,
then
yeah.
there's enough people who would be available to help with those plans to get them to the next facility?
We have a small team now. If we're looking at increasing the scope of that, it might include extra resources, but we have the process and we have the skill set. Just little, just 3 people.
here's just a point of curiosity. Are Jarvis hearings done through video now or in person?
Yeah,
Okay.
well, it depends on the county. Hennepin does
Right.
it through remote
Okay.
connections.
Oh,
So the
that's
person in
remote.
jail can be connected through
Okay,
Zoom.
so this problem with the people. Yeah, it can, you got a TV screen and the folks, you could do the hearing.
The hearing isn't the hard part. I think
Okay.
it's I mean, it's a good point to get to that sort of, from jail is you're saying that when you're talking about the group of clinicians who are administering the medication
Right.
and then monitoring the patient, over a period of time,
Mm.
and that's the sticky part. And I think what the sheriffs have been saying is, and others, is that if you're going to have some continuity, some like standardized level of care, if you leave it up to 87 counties to implement, you're gonna have, a
87.
whole different variety given the facilities and the training and that sort of thing. So I think the proposal here and understanding, shooting for the stars, I understand it may not be, financially feasible, but I think the idea here was, but this, for more remote areas to have kind of a response team, if that's what they want, to come in and provide the medical personnel to do the work. In places that's large enough where they'd like to have their own staff, there would be for those people to still be under state control, but be residential.
Yeah, and I think some of that is workable. I think as long as we allow for flexibility for some counties to partner with their local community health centers was an idea that was discussed the other day. What California is doing is I know that they're offering hands-on education and training to build up that capacity where that's reasonable. So they've got some different approaches depending upon what the barriers or perceived barriers are. And that's how the state is kind of responsible. They don't go and do all of the administrations themselves.
So it's about 3:30 right now. We're scheduled for a break. When we come back, we're gonna talk about, we're gonna discuss and we're potentially gonna decide, statutory modifications. So discussion and decision related to statutory modifications. Ask yourself whether we're ready for any kind of decisions to be made on this in terms of what we're gonna recommend. So that's a good topic. What do we want to decide? Are we ready to decide it? These are good conversation for the last hour of our meeting today. So, enjoy your next 10 minutes and then we'll be back.
Restrooms around the corner.
I have a question. Yeah, I guess I